Today is April 8th, 1986, and we're here at the Mayo Clinic in Rochester, Minnesota. It's a real pleasure to be able to interview for the AANS Dr. Collin MacCarty. Collie is one of the most beloved and highly respected neurosurgeons that I know, and he has served with distinction in many different roles. He's been president and prior to that vice president of the American Association of Neurological Surgeons. He's been president of the Neurosurgical Society of America. He was an active member of the Society of Neurological Surgeons, representing them on the board for some years. And throughout his career was instrumental in the development of neurosurgery in the United States. Collie, it's really a delight to be able to do this with you. And I thought that probably an interesting first question would be, why neurosurgery? What was it that got you interested in neurosurgery, and how did that develop?
Well, as you know, Ed, my father had a laboratory at St. Mary's Hospital surrounded by the operating rooms. And as a boy, I used to go to that laboratory and learn to do fresh frozen sections. That technique was developed in the laboratory so that you could diagnose tumors in any form, and at least 99% of cases accurately. And that, of course, gave me an entree to the various neurosurgical and other operating rooms. And as a boy, when my work was done in the mornings, I would go into the operating rooms and watch the luminaries at the Mayos operate. I remember Dr. Judd well. I remember once when he recognized me in the gallery. There used to be many physicians visiting in those days because surgery was in its prime. I can recall when Dr. Will would walk through the gallery, or through the operating rooms, and discuss the various procedures that they were doing. Dr. Charlie would come through, but he always talked about farming, never about surgery.
Isn't it true that Charles Mayo was one of the brothers that did the little bit of neurosurgery that was done very early on?
Precisely. Well, as I went around and watched orthopedics, Henderson, Meyerding, and so forth, I ultimately would end up watching Dr. Adson, who was one of the most colorful personalities I ever encountered. And with him was Dr. Craig, who frequently sat with me as a child when my parents would leave town, when he was a resident. So I knew him well, and he would allow me in the operating rooms. And the third neurosurgeon in those days was Jim Lermuth, who became Sir James Lermuth. Right. And when he left the clinic, he went to Aberdeen first and ultimately to Edinburgh, where he was knighted.
He was Regius Professor at Oxford, I think,
ultimately, or Edinburgh, I've forgotten, whatever. He left, and Dr. Love took his place. Dr. Love's wife was a daughter of a longtime friend of my family's. But anyway, as I looked around and observed things, it seemed to me that the field that I enjoyed most, and in fact the one that looked the easiest, was neurological surgery. Neurological surgery at the Mayo Clinic was not just brain surgery.
Yeah, well, you know, we don't accept residents these days who say they want neurosurgery because it looks easy. You know?
Well, in those days, well, I won't go into the details of it, but I did enjoy it. Maybe it didn't look so easy, but it seemed to me anybody could take the top off a head and get inside of it with any mechanical skill at all. So, but the main reason you asked me why neurosurgery is because at the clinic, neurosurgery included surgery of the nervous system. That meant the spine, including protruded discs. It meant peripheral nerves. It meant the autonomic nervous system. And as a consequence, the neurosurgeon was really more of a general surgeon than the general surgeons. Mm-hmm. The general surgeons were abdominal surgeons. The orthopedic surgeons were extremity surgeons. The neurosurgeon was in all body cavities and all extremities.
Well, that must have been fun and challenging, too.
Oh, it was wonderful. It was a wonderful era.
So then you went to medical school in Baltimore.
Yeah.
And knew you wanted to be a neurosurgeon or were you interested in the neurosciences in medical school?
Oh, I was interested. At the age of 14, it was a question whether I was going to be a farmer or a neurosurgeon, but I was afraid of cows. So it seemed to me neurosurgery was a logical choice. And I'm serious, that I did as a very young man, in those formative years, want to become a neurological surgeon, and for the reasons that I've just stated.
And you picked Johns Hopkins. Well, your father went to Johns Hopkins.
My father and my brother went to Johns Hopkins. That was the only medical school really I was interested in going to after I left Dartmouth.
How about some of the people that you encountered in medical school, the famous names and people in neuroscience that might have influenced you?
That was a wonderful, wonderful time. Of course, Dr. Dandy was in his prime at that time, but my contemporaries were the interesting people. In medicine, there was Barry Wood,
right.
Mac Harvey, Jim Havlin, who signed our marriage certificate, Harry Kleinfelder's syndrome, Joe Lilienthal. In surgery, there was Augie Jonas and June Sprong and Jim Mason and Bill Watson and Mark Ravitch, Ken Pickrell. It was just a galaxy.
So not only the faculty was
people.
Great, but the people
These were the residents.
Your contemporaries were
That's right.
Exciting.
The faculty, of course, was wonderful. Dr. Walsh and Dr. Woods in ophthalmology couldn't have been nicer. Langworthy, Ford, for heaven's sakes, in neurology. Perfect people. In psychiatry, Adolph Meyer was still there. And Esther Richards.
And
wonderful one.
Dr. Bard was doing
Dr. Bard,
neurophysiology.
yeah. And you asked me about him. I didn't really know him very well. Crow was active in ENT.
And Mountcastle, was he there then?
Vernon was 2 years behind me.
Yes.
We were friends as medical students.
He at one time wanted to be a neurosurgeon.
Yes, he would have been a good one. He may have been too smart to be a neurosurgeon.
Now, you stayed at Hopkins as a Halstead intern, and at that time were assigned to the brain team.
Yes.
What was that like?
That was exciting. It was one of the most exciting times in my life, and I never worked any harder in my life. Dr. Dandy was a hard-driving, superb technician. He operated about 4 or 5 times a week. The patients would come in after he had seen them in his office, which was on the floor below the operating suite, and he would go over them, and then we had to work them up, do the physicals and neurologics, and then the intern had to do the laboratory work, which we usually finished about 1 in the morning.
Right, I remember
And
that.
then we were up the next morning about 5:30 or so, setting up the operating room, and I mean, we had to sterilize the instruments and hand the instruments to him and be sure we had the right one. And he would come in and do the air studies. After Charlie Troland or Otenesac had put burr holes in, and they'd accompany him down to the X-ray department with the patient, and and then back. And it seemed to me, as I remember, every brain tumor got a ventriculogram. Right. I believe that was true. And then during the procedure, this was difficult because the only light in the operating room was a headlight on Dr. Dandy's.
And that was just a light bulb, wasn't
That
it?
was just a plain, ordinary light bulb. And you had to pick out the right instruments in the dark and hand them to him. And one time I handed him the wrong instrument. He looked at me with that light shining in my face and said, "Don't try to deceive me," as if I would. Oh, it was exciting. And he didn't believe, as you know, in indirect transfusions that were contaminated with anticoagulants. Right. He believed in direct transfusions, and patients were usually face down or on their side, and he wouldn't allow a needle in before the operation started. And so if you were the intern on laboratory, which I was, you had to come in that dark room and stick the vein, and then have the patient or the donor giving the blood. It was right in the operating room, and you had 3 syringes. They went from the blood was withdrawn from the donor, and then went to the patient, then to a wash stand and back, and went all around till Dr. Dandy told you to quit giving it.
Good heavens.
It was very, he had good reasons though. He said that whatever they put in it in those days, heparin or whatever it was, would cause bleeding, and
Sure.
he couldn't stand for that.
Right. Anesthesia was a little different then, too, wasn't it?
Gracie was still there. She was a nurse, anesthetist who Dandy had, I guess, for years and years and years.
Right.
I don't know how long, because, well, he died in '46. But Grace was remarkable. She was just she could do it just right. They used Averton and open drop ether.
Right. And wasn't Mrs. MacCarty a student nurse at that time?
No,
she was in the OR?
No,
Yeah.
she was a supervisor on Halstead 2.
I see.
Which was the large charity ward, and she's the one that got me to stay at Hopkins.
Ah.
And that's another story.
Yeah. Weren't you married when you were an intern?
Yeah, I believe we were the first.
In those days,
do you
it
want to
wasn't
hear
permitted,
about
was
that?
it? Oh, I think so.
Well, Dr. Farrar was then the acting chief of surgery, and I had accepted the position at Hopkins, and Margie and I decided, she's the only girl I had a date with at Hopkins, incidentally, and so we decided about time we got married. And so I said, well, how am I going to do that? They don't allow married interns. She said, well, go talk to Dr. Farrar. I said, okay. So I went over to talk to Dr. Farrar, and he said, oh, you can't get married. We don't allow married. He said, but who are you going to marry? And I said, I'm going to marry Miss Deal. He said, that's fine. You get married. She'll do you an awful lot of good.
That's a wonderful story. So now you probably could have stayed on for neurosurgical training at Hopkins, but decided to come back to Rochester.
Well,
is that right?
Dr. Farrar did ask me, Herb Sloan and me, to stay on.
Mm-hmm.
That was he asked me in the fall of '40, and as you'll recall, the American Board of Neurological Surgery was established that time. And the war was imminent, and I had agreed to stay on. And finally, as the spring came along, I talked to Dr. Farrar and said that I had been assigned to the Hunterian for the following
That's the
year.
research laboratory
right.
for the surgery.
And I told him I would like to get on with neurosurgery, and that the Mayo Clinic, which was my home, had an approved program, and wondered if I could drop out, because I knew there were plenty waiting in the line to take that place. And Dr. Farrar was gracious enough. Incidentally, as I recall, anyway, so I left Hopkins after my internship and came to the Mayo directly into neurological surgery.
Well, now, was Dr. Adson the chief at that time? Is he the one who signed you up?
Yeah, Dr. Adson, and another interesting part of that was that Dr. Adson signed me up, and my first assignment at the clinic was in pathology with Dr. Kernahan.
But your dad wasn't still head of pathology?
He was the head of surgical pathology.
Okay.
But I was reminded, he said, now don't expect to ever stay on the staff of the Mayo Clinic, because Dr. Adson and Dr. Craig and Dr. Love do not believe that neurosurgeons should be trained without having had a full training in general surgery. And because no one had come on the staff that hadn't gone through the general surgical program. But I said, well, I didn't decide to go into neurosurgery to stay on the staff of the Mayo Clinic. So that what I wanted was neurosurgery, and to get it done as fast as I could so I could get into the war, which was imminent. Yeah. And in fact, as you recall, the following December, the Pearl Harbor arrived.
So what was training like? It must have been very accelerated with the war going on.
Yeah, it was accelerated. It was
shorthanded.
You had to have a year of surgery, and my year's internship counted.
Sure.
And that saved me a year. Then I took 6 months of pathology in those days, and then 6 months of neurology, which was exceedingly good experience, both of those. And then I had the real good fortune to spend 3 months at the University of Minnesota with Dr. Rasmussen, the great neuroanatomist.
Right.
And I mean great neuroanatomist. par excellence. His sons were Ted and Wally, Ted the neurosurgeon, Wally the neurologist. And also during that time, it was my privilege to spend a lot of time with Dr. Payton, who was the first neurosurgeon up there, and Abe Baker, who was a neurologist. So it was a very, very fine experience, and Margie and I had a wonderful summer there. And then after that, I went on into the clinical neurosurgery. And then I joined the Navy in '43, and the Navy was good enough to let me finish my residency, and then even good enough when I went on active duty to reassign me to the Mayo Clinic.
Oh boy.
To do neurosurgery, which was a thrilling and great experience. And then after that, I went down, spent some time at Great Lakes, but the Navy experience, I think, at Bethesda with Dr. Craig and Dr. Hunter Sheldon and Robert Pudens was really an educational experience for me.
You did a lot of peripheral nerve surgery then.
Yeah, and I learned as much there as I think I did during my training in Rochester. Yes, we did lots of, all kinds of surgery. We did Smithwick's sympathectomies. We did lots of brachial plexuses, peripheral nerves, head injuries, brain abscesses. We resected brain abscesses, probably the first time.
Is that where you
we resected
did that?
them? Was at Bethesda. Was probably the first purposefully resected with antibiotic coverage in this country.
Well, I can remember following some of your papers when I was a resident, and the whole controversy about treating brain abscesses at that time is whether you should puncture them and drain them or excise them, and you had really spoken quite strongly for the concept of excision, and it turned out that that really did well.
Well, the reason, of course, was, well, first, Clovis Vincent in Paris was resecting abscesses, but he would wait till they were ripe. Well, by that time, a lot of patients would be dead. But then when antibiotics came along, a young chap from McGill, who was at Oxford during the war, named Bill Stewart, got the concept of resecting them. And Bob Pudens was over there in London, or wherever he was during the war, wherever he was assigned, and watching surgery, and Dr. Craig was over there too. And they said, we ought to try it, because actually brain abscesses usually didn't die of their infection. They died of increased intracranial pressure. So we treated them like you would a brain tumor. Take the abscess out and give the patient room. And we didn't lose a single abscess. We lost some multiple abscesses, but a single isolated abscess. And I think it was a good concept. Nowadays, of course, many abscesses, I presume, are prevented.
Well, right, and with the scan, you can follow their progress very precisely from time to time.
These days, Dr. Adson, I remember, resected a brain abscess back in the 20s, and he thought it was a brain tumor. And it was done as an emergency one night. He didn't open it up, and he put it in my father's laboratory. My dad came in the next day and said, how's so-and-so doing? And Dr. Adson said, well, the patient's doing fine. Why? He said, my father said, well, you resected a brain abscess. He didn't know. But Dr. Adson never quite accepted the idea of purposefully resecting them. Although McEwen, I think, if you look into his book, his classic monograph on infectious diseases, he was essentially doing that. He was debriding them. And, well,
now you had the opportunity to work with some of the pioneers. Could you just give little thumbnail contrasts, say, of Dandy and Adson and Craig and Love, and how they were similar or different? We didn't talk about the Dandy story about taking you to the ball game. I guess everybody
Well, that story is well recorded by Dr. Walker. That brain team that went on that adventure, I should say, to watch the Baltimore Orioles play. It was really rather exciting, just trying to get the patient off the table, and,
so you could make the game.
we could make the game by 1 o'clock. Was a little bit of a trial, and he invited the whole brain team. So who's going to take care of the patients? Well, he said Pickrell will take care of them. Pickrell had been on the brain team a couple years before. Then he was off in plastic surgery or something at that time. But anyway, we got out there, and sure enough, he had two of his children, I think a son and a daughter, were on his right side, and then Trollin, this chief resident, was the first on his left, and then Franco Tenesac next, and then was my position, and then Herb Sloan was at the end of the line, and he asked us if we wanted anything to eat or drink, and the two big residents got a beer and 2 hot dogs, and Herb and I got a hot dog and a Coke. He did pay some attention, though, because the fellow who was pitching for the Orioles happened to be a classmate of mine at Dartmouth. So I knew him. So his name was Ted Olson, as I remember.
I gather things were pretty hierarchical.
That's what they say. Yeah. I suppose.
Was that true at Mayo as well?
What?
Was it true at Mayo as well?
Oh, yes, it was. I think throughout medicine was that way.
Isn't there an interesting story about how Dr. Adson approached Dr. Mayo about taking over neurosurgery?
Yes, I think that is a great story. And Dr. Adson loved to tell it. He might have embellished a little. But it began when he was a resident in surgery on Dr. Beckman's service. Beckman was doing what little neurosurgery, brain surgery there was in those days. And Dr. Judd did some, and Dr. Charlie Mayo did some. But anyway, Dr. Beckman got a cavernous sinus thrombosis from an abscess by his inner canthus, and he died. And at the memorial service, Dr. Will turned to Adson, who was Beckman's assistant, and said, "Well, you'll have to carry on for Beckman." So, and that means you'll have to do some neurosurgery as well as your general surgery. And he said, "Feel free to refer any cases that you wish to Cushing or Ellsberg or Fraser, but do what you can." So Dr. Adson did that and got interested particularly in peripheral nerves.
Right.
Dr.
Sympathetic
Adson,
surgery?
Yeah, but not early. Early was peripheral nerves. And Dr. Adson was an extremely gifted anatomist. He was a fine anatomist, around the neck particularly, and in the extremities. Well, anyway, the department really began in Beckman died in 16, Adson went on the staff in 17, and he did some work on regeneration of peripheral nerves, and he was presenting that work at the American College of Surgeons meeting in 1921, and he presented the peripheral nerves, and Dr. Ellsberg, of course, the spine, Dr. Fraser presented the work on trigeminal neuralgia, and Dr. Cushing presented brain tumors, and Dr. Will Mayo chaired the session. And at the completion of the session, Dr. Will said, "Well, gentlemen, we've now witnessed the birth of a new specialty." I don't know how accurate that was. But Dr. Adson was quite pleased, and yet he was a little disappointed that he wasn't being remunerated or given the respect that the other 3 participants had. And so he returned to his room, and he was smoking a big black cigar, which he smoked and smelled the room up, and he may have been enjoying some other things, but I don't know that. And Dr. Will came in, and Dr. Will never didn't allow smoking, even on his boat by anyone, or any alcoholic beverages. And he came in and told Dr. Adson that he ought to develop a department of or section, they called it in those days, of neurosurgery at the clinic. And Dr. Adson had enough courage to say, but I'll only do it under my circumstances, which he outlined. 1, they should have the same respect as the general surgeon. 2, that they should get the same pay, which was the highest pay scale. And 3, that he be surgeons of the nervous system, not just the brain and spinal cord, because Dr. Adson wasn't interested as much in brain surgery as he was in the periphery. And Dr. Will agreed, and it was that way through my lifetime.
It's been that way since, and of course you held to that concept of neurosurgery.
That's right, and we had some difficult times through the years to maintain it, but we were able to do that.
But it was important for the board in its deliberations as well, I would imagine. I mean, this whole concept...
Well, the sympathetic surgery, most neurosurgeons did not do sympathetic surgery. We did. And to hang on to that was a little bit of a battle because, as you recall, hypertension had no drugs for hypertension, and we did sympathetic surgery for that. Same with the peripheral vascular disease and so on.
Well, I guess turf battles will always
Still
continue
on.
and still
That's
go
right.
on. Yeah.
But I am glad that during my lifetime I was allowed to operate throughout the entire nervous system.
How about experiences you had with Dr. Craig and Dr. Love and maybe some of the famous neurosurgeons who visited or you visited during...
Well, I guess I knew many people. Dr. Sachs was a classmate of my father's, and so we used to meet and see them at meetings, and Ernie Sachs Jr. was the same age as I, so we knew each other well, and he ended up at my alma mater at Dartmouth as the head of neurosurgery there. Dr. Cushing I never met. My father corresponded with Dr. Cushing throughout their lifetime, from medical school on to when Dr. Cushing died in '39. But I have his letters, and they've been published in the Journal of Neurosurgery, some of them. Dr. Dandy, I think, was as fine a brain surgeon as ever lived. He just had the greatest facility to remove tumors. I don't know of anyone any better. And as I say, Dr. Adson was a great anatomist, and he was wonderful in the extremities and the abdomen and so on. Dr. Love was a very skillful neurosurgeon, in the mold of Dandy, really. When I was on Dr. Dandy's service, he came out to watch Dr. Love do discs through the interlaminar approach. And so Dr. Craig had the greatest composure in the operating room of any man in any specialty I ever saw. One time I walked in his operating room, and things were pretty hectic. And he looked, and all he would say when things were going bad is steady, steady. He looked at me this
Saying
day,
that to himself?
to the team.
To the team.
Never another word. He looked at me this day and he said, "I think we've gone a little far. We're resecting part of the midbrain." It just, the absolute composure. It was a glioma that had migrated in, and he says he went a little far. But he never lost his temper, never once. Wonderful.
Did Oliva Krona come to visit?
Yes, I took him on rounds, and I got a lesson from Dr. Oliva Krona, Professor Oliva Krona. I showed him a anterior communicating aneurysm that I had not as yet operated. Showed him the angiogram. There's a lot of spasm. And he looked at me and he said, "I think you better operate before that spasm lets up or the patient will bleed and die."
Really?
Yeah, this was back in 1951, I think, or two, in there early. He was a wonderful man. I didn't know him very well because he was very quiet and stoical, but he surely knew what he was doing. He I think, probably was in the class with Dandy as a brain surgeon.
How about Jeffrey Jefferson?
Jefferson, yes, he came. I knew him. He talked here, and his son Tony was here one time. I knew him not well. They were magnificent people. Faulkner, I knew. Faulkner spent a year at the clinic in research.
Right.
Yeah.
Fragoni,
I knew Fragoni exceedingly well. He was a good friend of my family's. Used to come to dinner. His father was a professor of medicine in Rome, and which automatically made him Mussolini's physician. We used to have some mighty fine talks about those things. But Piero Fragoni is a great gentleman and a great man in my estimation.
How about some of the people who trained here along the years?
Well, there's some
like
wonderful
Sheldon
people.
And...
Yeah, well, there was Hunter Sheldon, and I've been following Hunter Sheldon around since I was a little child and working in my dad's laboratory. He was a resident in those days, and I had to follow him around just like a little child. He was a superb athlete, a superb neurosurgeon, and a superb guy, as far for my money. And then there was John Raff, who was a famous boxer, incidentally.
Really?
And
I
he
didn't
was
know that.
I think he was the welterweight amateur boxing champion, gold medalist or some such. Ed Fincher was a wonderful man who went down to Atlanta and established a fine residency there. I've mentioned Frigoni, Faulkner.
Dwight Parkinson
mentioned.
and,
now Dwight was
Bob White. They're really
yeah,
your students. They're sort of
in my class. Dr. George Eney, I think, was one of our outstanding people. He, as you know, went to Baylor and became really the first permanent chairman at Baylor. Then Dwight Parkinson was behind me at Dartmouth, and incidentally, he was 4-time intercollegiate figure skating champion, and he was just as skillful as a surgeon. And Dwight came to us when I was on the staff after the war, and we've been close friends ever since. And he went from Rochester to Winnipeg, where he just now stepped down as the chairman of the department there, and been succeeded, as I understand it, within the last few months by another one of our residents, Norm Hill. And Norm was an interesting fellow. He was a professional football player. But then up in Canada, as long as we were there, Peter Allen up at Edmonton spent considerable time with us. And of course, Ted Rasmussen had all his neurology with us, and I was a good friend of mine. Then he went to get his neurosurgery with Dr. Penfield. In Japan, we've had some wonderful people there. Jim Matsukato comes to mind immediately. He was the youngest professor of neurosurgery in Japan at one time.
Is that so?
Then 2 of Dr. Sano's people were trained with us, and then Suzuki's young associate at Matsumoto, Shige Kobayashi, is there. And then, of course, in this country, there's been Bob White, Irv Cooper, who I think the world thought the world of, both of them.
Well, you've always had an international interest, haven't you? You were secretary of the World Congress when it was in New York. And,
that's right. And
I guess got to know a lot of neurosurgeons
that's
around the world.
Precisely right. And Tony Becerra down at Columbia is one of our outstanding residents. And then those neurosurgeons that founded the Clinic Alondras in Mexico City,
right.
Hernando Guzman West and Peter Angulo Rivero and Ignacio Olive were trained with us, and they're outstanding people. Yes, we had a philosophy when I became chairman that we would train 1 foreign medical graduate and 4 American graduates a year, admit them a year and train them. And that went on, and I think it was a very profitable thing for the time.
Well, now, in your tenure as chief, I mean, you had a tremendous influence on education, neurosurgical education, but also on education in general at the Mayo Clinic and even farther afield than that. Maybe you could talk about neurosurgical education first and then a little bit about the medical school and your role in that.
I think I got interested in education. It goes back to my father, who started a clerkship at the Mayo Clinic around 1911 or 12, before there was a residency program. And he would take junior medical students, usually from Harvard or Hopkins or Penn, and take 10 of them a summer that work in his lab. And they'd spend the mornings working in the labs, and there'd be lectures. They could watch a surgery. And then the afternoons were delightful because we played tennis and golf and went swimming. And it was a lovely time. And then frequently go on canoe trips into the Quetico in Canada. But that started, and that persisted for until the World War II. The residency started in 1915, the foundation. But this was a great source of residents. It was a great opportunity for, I think, those young medical students to see a large practice of medicine. I remember Dr. Arnold Rich at Hopkins, and Dr. Reinoff at Hopkins were summer students the same time that Chuck Mayo was back in the 20s. And there were many others. Ted Scarf of Columbia was a summer student. I could name many more, but that was really the first undergraduate education at the Mayo. Well, as time went on, that clerkship ceased. I happened to be on the graduate education committee, which was the education committee of the clinic in the early 50s. And we were always looking for ways to recruit good medical students from the fine medical schools, because we didn't have one. And we thought we better start another clerkship again. And so that we did, and we got a very fine young man from the University of Kansas, who had been a famous football player and very academic and a great fellow. And so he came and stayed at our house and for a while, and then brought his wife, and they moved to an apartment and spent the summer. Well, I asked him to critique what were the possibilities, what was wrong, what was right. And one of the interesting things that he said, well, I happen to have enough money to afford to do this, but most medical students don't have. And therefore, I would suggest if you're going to start a clerkship, that you pay the medical students. So I took this critique back to the Graduate Education Committee, and everybody agreed. So it restarted. Well, those are the things that kept me interested in other things than neurosurgery. And I was on that committee off and on, or I was on it till I became chairman of the department. Yeah. And that was in '63. And then I went off the committee until the late '60s, and when the time came to consider having a medical school, and I had to be president of the staff in 1965 and '6. And my interest in a medical school was enormous. I thought that was the thing we needed of all things. And fortunately, others had thought of it probably before I had. And so it was ripe. And I remember I think most of the staff did not want a medical school.
Certainly there were mixed emotions about it.
Well, and I think with an educated guess in what we learned, I would say that about 55% didn't want a medical school. But what we did was, when Howard Rome was president of the staff, as I recall, and I guess I was a counselor or president-elect or something, we invited members of the staff to our weekly luncheon meetings. We'd invite 3 at a time to get their input, and they could get our input. And that way, over a period of 2 years, we saw a large proportion of the staff. And I think by the time that I was president and gave my address, which was on why we should, or what we should do about having a medical school and how to go about it, I think by that time a lot of the staff were convinced. And then I think that was an effective document. There were many others.
Well, it's certainly been a success since then, this medical school venture.
Yeah, and I think one of the big things was after it was decided that we'd have a medical school, who's going to run it? And I happened to be, again, fortunate to be on a committee to select that person. I may even have been chairman of it, I don't know. But the board, of course, had their ideas, and their ideas jibed with our ideas, and that person turned out would have really a dual responsibility. He would be dean of the medical school and director of education. Now the directorship was an important position because that meant of all education at the clinic.
Including the residents.
Yeah, everything. Yeah. See, the first director was Wilson, who was my father's superior in pathology, and then he went into that. And the next one was Donald Balfour, who was a general surgeon. The next one was Victor Johnson, who was a physiologist from Chicago. And the next was Victor Code, a physiologist, or Charles Code, a physiologist. Well, then we selected, I think, one of the most brilliant men and the finest persons I ever known was Ray Pruitt.
He certainly was.
And he came from Baylor. He had been at the clinic as a cardiologist and is an associate director, then to Baylor as dean, and then chancellor, and then back to us.
And you were in a position in the graduate education committee when the residents had a revolt or something.
Oh yes, that was
those days of the 70s when the residents didn't want to toe the line.
Well, they wanted more money, and in that regard, they won it. They got more money. But in turn, we then, of course, way back in the 50s, we had to figure out some way. Some of us thought the Mayo was training too many residents.
Right.
And I was particularly interested in the surgical aspects of it, so we had to cut down. Mm-hmm. And so initially, we started with what we called surgical techs. And these were people who were high school graduates without nurses training, who we could train to hold retractors and clean up the operating rooms and get rid of some of the menial chores of the resident.
Of the real junior residents, yeah.
And then we still had to cut down, and by the time I got to be chairman of the department in the 60s, we determined that we had to really reduce neurosurgical residents. And how are you going to do that with a, when you're doing about 300 brain tumors a year and all the other things? So we decided to train nurses and have them become nurse physician assistants. And that apparently has worked out splendidly.
Yes, we have a large component.
We had a particularly gifted young lady to do it. It was the daughter of one of our staff men who had her BA degree, AB degree, and who was a straight A student practically. And so we hired her, and she came in and was a nurse. Right. And she set out the protocol, and we followed it at her suggestions, and her name was Debbie Wilson.
Right. Well, that certainly has been a success, and I guess we're still facing the same kinds of problems with manpower and training residents.
That the residencies, neurosurgery is going down to 2 residents a year.
Well, that's
There's
the
talk
goal.
of that.
That's the goal, yeah.
We went down to 4 when I was there. That meant we had to drop the foreign graduate usually. Yes. But I certainly concur that...
Well, the other thing that happened while you were chief was this trend towards subspecialization in neurosurgery really flourished, didn't it?
That's right. It was obvious. The first interest was in carotid surgery. Who should do that, for instance? The vascular surgeon or the neurological surgeon? Well, we lost the skirmish but won the battle because through the influence of some others that I couldn't control very well, the vascular surgeons started doing the carotid surgery, although a couple of us had done a couple of them before. But in the long run, it seemed appropriate to get a well-trained vascular neurosurgeon.
Right. And
of course, that person is Thor Sant we got from Dr. Murphy. And he then the vascular surgeons lost the battle.
Yes.
Because then it came back to Dr. Sant, Dr. Peatgrass. And then people like you came along from Johns Hopkins with special interests, particularly in the pituitary and the transphenoidal operation and acoustic tumors with the ENT people. We were just starting to use a microscope in the 60s, and about all we used it for was acoustic tumors and intraventricular tumors. Mm-hmm. I couldn't stand to use a microscope on a peripheral nerve or a hypoglossal facial. I tried it, and I just was, that was for the younger people.
Well, at least you didn't prevent younger people from doing
it. No, of course not. On the contrary, we encouraged it. My only claim to fame in the microscope is I was the first neurosurgeon to use one at the clinic.
And you fostered research in neurosurgery where it really hadn't played a major role probably before.
Everybody sort of piddled at research, when we decided to take the spinal cord out of a human being, went over and took them out of dogs, and that was a sort of opportunistic research,
yes,
so to speak. Though Hank Sveen had some interesting research going, he was able to create cerebral edema with psyllium seeds,
right,
and then he started treating it with cortisone, which, and then, as you know, Dr. French and his group came out with the steroid treatment of edema in humans. But we had what I call opportunistic research, and then what happened is we heard about Fred Kerr. When he took his boards, George Baker was on the board, and he said, boy, Henry Schwartz has got a brilliant young neurosurgeon who's now working with Bob King. So we hired Fred to come to the clinic and set up a neurosurgical research lab and teach neuroanatomy and neurophysiology, which he did supremely well, I think. And then we encouraged people like Dr. Sant, when they came here, and you, to have your own lab, and which I understand you still have.
Yes.
So we really ended up in the Department of Neurosurgery with 3 laboratories, which I think enhanced our education. We encouraged people to get PhDs. John Raft, Hunter Sheldon had gotten PhDs. And later, Dr. Irving Cooper got his PhD. Bob White got a PhD.
I think those themes in neurosurgical education really are continuing now, and it'd be interesting to see how they evolve in the future, but the integration of research into the training is standard now, and of course the subspecialization is something that most larger centers have
Well, you see,
done.
we had to give up going to, when Dr. Asmussen, I think when he died, he retired. I guess he retired. We didn't go up there anymore, and we didn't go up after the war.
Right.
That was, it wasn't research, but it was a good exposure into that academic environment.
But you really, during your career, were doing essentially everything. I know you did plenty of aneurysm surgery, and didn't you start doing some hypothermia in the days when that was?
Oh, that was one of the most exciting part of my career. Al Eline and I did most of that surgery. I guess I did more than he. Well, I guess I did most of it. Dr. Miller wasn't very interested in it, but Al was, and Al was, I think, did the first one. And John Kirkland, of course, we had the tremendous advantage of having John Kirkland as a cardiac surgeon. And that was a very exciting time. So we did, I think, 70-some aneurysms under profound hypothermia.
This is profound hypothermia. Did you try to stop the heart as well?
Oh, they all stopped.
Yeah.
70, I think it was 75 when we finished. Now, there was disadvantages, and I don't know why. Well, the heparinization was the big disadvantage. So it would take 6 hours or so to do one of the things because you had to reverse the heparin.
Sure.
If you closed the head up too soon, they would bleed postoperatively. And then, of course, you had a thoracotomy or a midline sternotomy. It was
quite a tour de force.
It was a big, big scene.
But I think that, you know, your international reputation was probably built on the meningioma and glioma surgery that you did. And maybe you could just reflect a little bit about that. I mean, you wrote the book on meningiomas.
Well, that was a small monograph. It was dedicated to the residents. We had a series of residents who were interested in meningiomas, and they wrote a series of theses on various types of meningiomas. And the basis of that little book was simply the theses that the residents had written and the work that Aliva Cronin Cushing and what's her name? His secretary.
Eisenhardt.
Louise Eisenhardt had pioneered, and then only my contribution was the surgical technique.
Sure, but you went when you went to Japan, you reported on how many meningiomas?
A couple thousand, but in detail we reported on 800 and some. I've forgotten, but it was over 2,000.
Yeah.
And that was a
enormous experience.
Enormous experience, and we had good results, I think, in the modern times.
Well, I can certainly remember your radical surgery for the removal of low-grade gliomas in the thalamus and in the basal ganglia, and how impressive
Well,
was that you could
we,
get away with
Jim
that.
Mazzucato was assigned the task of finding out technically how many glioblastomas could be removed and still have a viable individual. And so he went to the pathology lab and got out all the glioblastomas, and we set certain boundaries. If they invaded the thalamus, that was probably inoperable. If they didn't invade the thalamus, how much of the hemisphere would have to be removed? Well, it turned out that about 17% of glioblastomas, if I recall the figure correctly, were technically curable. The only trouble is you'd almost have to divide that in half because you'd hate to treat the dominant hemisphere that way. So let's say you come down to 8 or 9%. I still think that people weren't quite aggressive enough. When I was a resident, they weren't aggressive at all. They biopsied them and quit, and they'd swell up, and the mortality rate was horrible, over 50%. Well, Dr. Dandy would resect the glioma, and his mortality rate was very low, simply by giving them room. And that was my philosophy always, and I always usually tried to cure glioblastomas and had the good fortune of curing one or two, probably.
Well, you did some radical surgery in sacral tumors as well that I think you were pretty well known for.
Well, that was very exciting. Do we have time for to discuss that?
I think we should.
That was one day I was operating on a chordoma of the sacrum, and the standard operation was to just curette it. And you weren't really doing much, and save the nerves, and that was it, and maybe irradiate it. So I went down and told this nice fella, I said, geez, I tell you, you've got a bad tumor there, and I can't get it out without wrecking you. And he said, well, what do you mean, wreck me? I said, well, I'd cut your nerves to your bowel and your bladder and all that. And he said, well, isn't that going to happen to me anyway with this tumor? I said, yeah. I said, I'd probably get into your rectum too. You might die of infection. He said, I'm going to do that anyway, aren't I? I said, well, maybe. He said, well, why don't you just do some operation on me where you take this whole business out? I'll take the consequences. So I enlisted the help of John Waugh, who was a superb general surgeon. I said, John, you got to keep me out of the rectum. I'm going to take this guy's sacrum out till I get around this tumor. He said, well, okay. Well, we did it. And we didn't have to take his sacrum out. We could leave the upper two segments of his sacrum were not involved with tumor. So we put a catheter in him and sent him back to his room, and the guy looked fine. And so I asked Alex McLean, who was on the staff neurology, to check him out neurologically because we figured he was probably going to be impaired. And Alex went over him and he says, Collie, I can't find any neurologic deficit in this fella. I said, well, I was cutting the nerves right and left. He said, I can't help it. Well, it so happened that I had cut, in retrospect, 4 and 5 bilaterally. And the guy had perfectly normal bladder function and a very undetectable sensory deficit. Well, we learned a lot from that, and incidentally, that fellow lived for 23 years and died of a heart attack, and he had no residual tumor. But that was the first case of resecting the sacrum for chordomas and other tumors and presacral tumors. I never saw one invade the rectum. They never do. The only time we got into the rectum is I fumbled a little, and John Waugh wasn't around, so I had to sew it up myself, and nothing happened. But we did learn a very good lesson. That is, if you take 3, 4, and 5 sacral nerves out, they have a saddle anesthesia and inadequate and a flaccid bladder. If you leave 1, 2, 3 on one side, 2, 3 on the other side, and take 3, 4, 5 on one side and 4 and 5 on the other side, they still will have good bladder function. Preferably, you want to spare the upper 3.
Sure.
So that was, I thought, a significant contribution not only to physiology, but as a surgical technique, because this tumor is usually curable.
Yeah, I think
If
that
you
was
can
really
do
was a major,
Yeah.
major advance.
The other exciting thing that a patient suggested to me was at Bethesda, we had a Marine sergeant on the service who had symptoms of a thoracic spinal cord tumor. I operated on him because his cord was a little swollen, but he was basically neurologically normal, so I didn't do anything. Well, to make a long story short, this guy, after I left the service, went on downhill and was operated again and had a highly malignant glioblastoma.
In the cord?
In the cord, the only one I've ever seen. So he wrote me at the clinic and asked if I would see him. And I said, sure. And so we talked this thing over a bit, and he said, will you operate and just verify what they found? And I did, and by golly, it was a grade 4 astrocytoma, glioblastoma multiforme. So I closed him up, said, geez, Bernie, his name was Bernie Brown, I never forget him. I can't do anything to you. It's a highly malignant tumor. And he said, well, it's been there quite a while, and I'm useless now, I can't move, and I'm paralyzed, and I'm spastic. I said, well, I don't know if I could cure you if I took your spinal cord out. He said, well, why don't you do that? I said, well, that's never been done to my knowledge. And I don't know whether you could survive if we took out all that spinal cord. He said, I'll tell you what I'll do. I'll go out and do some dogs. So we did some dogs, and the dogs didn't survive very well anyway, but at least their pressure stayed up. Mm-hmm. And so Bernie came back, and I said, okay, we're going for it. And I was really excited because we got up to the cervical cord to get above the tumor. Right. We were right up at C8. And then Doherty, finally we got to C8 or C7, the dermatonal segment in the cord. He said, you're free of tumor. So then we took the whole cord out.
From there on down.
And the darn tumor was invading the lumbar muscles where it had been biopsied. So Bernie survived, and when I cut through that cord up there, I thought, I didn't know what was going to happen to his blood pressure. And neither did Faulkner, right, who was the anesthetist. We didn't know what was going to do. But nothing happened. And he became flaccid, became very wonderful, useful. Mm-hmm. The only problem is the darn tumor metastasized up into his ventricles.
My goodness.
So it was an unusual spinal cord tumor.
We were talking about spinal cord surgery, and I recall you did some fairly aggressive work with ependymoma too, didn't you?
That's right. Of course, the pioneer was Dr. Ellsberg, who, if I recall correctly, took an ependymoma out from the cervical cord to the conus once. Yes. I believe that was accurate. But, as was true in brain surgery, the spinal cord is better without leaving any tumor, intramedullary tumor, if you possibly can, because it also swells and the neurologic symptoms can become devastating. I remember one of the most aggressive ones was a lady who had been diagnosed as having multiple sclerosis, and to shorten the whole thing up, she couldn't walk very well, and she was young and badly incapacitated and ataxic, but she had no symptoms above her foramen magnum. Well, we did a myelogram. She was obstructed at the upper thoracic level, about T5, as I recall, and so we operated on her, and she had an ependymoma that went from the entire length of her cervical cord down into her thoracic cord. And so as per our understanding, we were going to get it out. So we took it out, and it's of some interest. I believe she was the lady who had an associated syrinx and some hydromyelia with it. In other words, she had a cyst off to the side of the central canal, and had a dilatation of the central canal below the tumor. Well, she survived, and she survived well, and she was operated before we wrote that book in '61, I think it was, and she is still alive and still functioning. She's raised a family. One of her children, I think, played football at Stanford. But anyway, the point of the issue is Ellsberg told us what to do, and very few people, I guess, were aggressive enough to do it in those days. This was in the 50s. And she was such a gratifying case that that was the general philosophy, my general philosophy. If you got an appendymoma, take it out.
But you followed through on, right before you retired, you had done some work on post-laminectomy deformities of the spine, which I think was very important.
That's right. We used to think, as you know, that children, they usually got a swan neck after surgery in that area, and we used to think it was due to interruption of the facets. Well, as a matter of fact, it wasn't due to interruption of the facets, as we now know. It was due to the removal of the stability of the posterior aspects of the lamina, and that the only way that we knew how to correct it and prevent it was to do anterior cervical fusions. And it was really due to collapse of the bodies because of the cartilaginous plate hasn't developed yet. And we also learned that if you do a similar laminectomy on an adult, you didn't get the same result. So that was a contribution, and that followed some other observations that Shozo Yoshiwaka, who was a resident here from Japan, from Dr. Sano's service, some of his observations on our foramen magnum tumors. Right. He was alert enough to pick up this swanning, and then in the foramen magnum tumors, the question came up, why did so many of them, were they diagnosed as multiple sclerosis, and why did so many of them have peripheral, mid-cervical and lower cervical cord EMG findings and neurologic findings with lower motor neuron disturbances. And here they got a meningioma of the foramen magnum. Right. Well, I guess no one really knows the answer to that, except they postulate, of course, that the blood supply to the cord is compromised by the tumor, and the pressure of on the anterior spinal artery, and resulting in anterior motor neuron symptom. I think that was a pretty good contribution. He reported our benign tumors, and that was one of the findings. And Jasper Dalby was the electromyographer and neurologist who was interested in it. Right. He confirmed these unusual electromyographic findings.
You had some laboratory work in spinal cord cooling too, I think, back when that was a hot item.
This was when we were doing a profound hypothermia, protecting the brain for aneurysm surgery, and Bob White was a fellow here. I think Bob must have been here 7 years or so. He got interested in neurophysiology, and he worked with Dave Donald, who was a very imaginative and fine research person. And so one day Bob White came to me and said, you know, if we could protect the spinal cord like you fellows are protecting the brain, if we could get an injury in time and cool the cord, maybe we could reduce the amount of edema and the amount of damage. And so I thought that sounded like a pretty good idea. If you could rig up something that would circulate a coolant in the subarachnoid space, and you could do it promptly, and then you might accomplish something. And Bob and Maury Albin. Maury was a resident in neuroanesthesia. And so the two of them got together. I remember I helped them with the first laminectomy, and then they developed the whole thing about the consistent damage to the cord, and they were able to measure it accurately so they could tell how much weight dropping on the cord would produce damage and what wouldn't, and so on. And Bob made a career of that, and I think Maury did too.
Yes.
They both went with Frank Nolson, and Frank assigned Bob to Metropolitan Hospital, and Maury stayed with Bob at the Metropolitan. I think he subsequently went with Peter Janetta to Pittsburgh. But it was exciting times. I didn't have much time for the laboratory, and I wasn't really trained for it, but to have these young people in our residency program who were interested. It was a stimulating thing as far as I was concerned.
You had a lot of interaction with neuro-ophthalmologists too, and not only from
That's
the
right,
pituitary
yeah.
tumors, but for orbital tumors and other diseases
Yeah.
as well, I think.
I guess yes, we did a lot together. First, the meningiomas. I remember another woman that came here with a early optic atrophy and considerable visual loss, which cleared when she delivered her baby. That I thought was a neat case because she had been diagnosed rather by good people as having multiple sclerosis.
Sure.
Well, when she got up to see us, she had a recurrence of her visual loss and more optic atrophy. So I don't remember we did a angiogram probably. Anyway, I took her tumor out, which was a meningioma.
Sure.
And I'll never forget, two things came of that. First, I said, well, now you may go home now. And she said, no, I'm not going home. I'm going down to the Mayo Clinic because I couldn't see it when I came.
Oh, gee.
Because her vision in her one eye came back to normal. The other thing that came of that was, why did she lose vision during pregnancy?
Right.
Well, Bob Lyon, who was really very fine resident, immediately solved that one. He said the tumor swelled up during pregnancy, just like women swell up during pregnancy. And so we had the opportunity to operate on some pregnant women with meningiomas of the
sure.
tuberculum cell, and sure enough, they're a different looking tumor. They're filled with inter or extracellular fluid from their pregnancy. So that was an observation I thought we made, which Bob helped.
How about the uveitis? That was another observation.
That was another thing, and Tommy Kearns, the ophthalmologist, really put his finger on that. He had a patient with uveitis who had a fit. He asked me to see the patient, and so I did an angiogram and took parasagittal meningioma out, only it wasn't a parasagittal meningioma. We thought it was. It was a reticulum cell sarcoma.
Or lymphoma with today's parlance.
Well, whatever it's called. We call it reticulum cell sarcoma. So then we promptly learned that if a patient has uveitis and a fit, they've got reticulum cell sarcoma of their eye, and they've got it in the brain. And now with the scan, when the CAT scans came along, it was pretty easy to diagnose. And that was presented in 1969 at the World Federation of Neurosurgical Societies in New York, and you were helping Dr. Walker with that, as was I, his secretary. And it rather escaped notice. And Bob Van Scoy was the internist resident who worked those cases up, and he didn't get around to publishing it until 1972 or 4 or something. And by that time, Tommy Kearns' name was taken off, and someone else's was substituted. But that was but to carry that one step further, Helmut Buechner, who is now on our staff and came from Germany, instead of having to do a craniotomy or do anything else, he can make the diagnosis by penetrating the eye and getting a biopsy.
Examining the vitreous,
getting the vitreous. And that was, I think, reported to him.
You did a lot of pioneering work with orbital tumors, or a lot of work with orbital
we did a lot of work. Dr. Dandy, of course,
pioneered it, I suppose.
he was the pioneer. And then we used to see a lot of endocrine exophthalmopathy, the Graves' disease. And it was very disappointing the way the ophthalmologists were taking the lateral wall off. They got about as much off as the size of a good burr hole. And so the endocrinologist asked me to look into the subject because, after all, Dr. Dandy had been operating on the orbit transcranially, and Dr. Adson and so on. And it became apparent to me that if you're going to operate, you might as well operate and really give that orbit room. So I always closed the eye because I saw one of the older men's cases lose an eye because of the swelling overnight and got an ulcer and so on. And then we ultimately learned to take the roof, the lateral wall, and the sphenoidal wing off right down to the optic foramen.
Right.
And as far as I recall, we had brilliant results. All the people, if they had papilledema, that disappeared. And essentially, all of them got relief of their exophthalmopathy, and not total cure. Of course, that's a...
Well, that operation has been essentially supplanted by the transantral approach, but we had to do one or two just recently because the antral approach was insufficient.
Well, that's right. We ran a parallel series with Dr. DeSantos and me, and the 10 transcranial cases had absolutely no complications.
Right. Do you see any trends in neurosurgery or any visions of what the future might hold?
Well, I think this business that Pat Kelly on our staff, or your staff, is doing, it must be exciting with all the new stereotaxic equipment, with the laser surgery and all the things that can be done at the basal ganglion level. I'm not in a position, though, to really prognosticate on how successful it's going to be. But I can only say that I think I lived during the golden years of surgery of the nervous system. And that's now, with all the, I think the subspecialization is great. And I'm proud of my role in getting people like you and Sant and Pete Grass and all of them in on this sort of thing. But I liked it my way.
That's great. Thanks a lot, Dr. MacCarty. I think our challenge is probably one of keeping the golden age alive and well, and I hope we'll be able to meet the challenge.
Thank you, Dad. I really appreciate you doing this. This interview has been informal and unrehearsed. Consequently, many events, friends, and colleagues were not discussed. As examples, we did not mention our contributions to the understanding of the Nelson-Salasa syndrome. We also neglected to discuss many of my neurosurgical friends, like Bland Cannon, Bob Wyan, and Lee Christopherson, former Mayo residents, as well as staff colleagues like Bill Dodge, Al Roten, and Bert Onofrio. Time did not permit us to elaborate on the contributions of others that we mentioned too briefly. I am grateful to so many. Thank you.